Hello, everyone. Welcome. Thank you so much for joining the POCUS Certification Academy for today's POCUS Bytes webinar. My name is Daria, and I will be your webinar host today. The webinar is now beginning, so all lines have been muted. Please use the Q&A box for any questions or the chat box for comments you have throughout the webinar. Today's topic is basic point-of-care echocardiography views, and our speaker is Dr. Magdy Imam. Welcome, Dr. Imam. Thank you so much for taking the time to present this valuable information for our community.
Good evening, everyone. It is good evening for an hour in my time. Thank you, Dara. Thank you, POCUS Academy, for giving me this opportunity to present this presentation about the basic point of care ultrasound. I will start sharing my screen. Okay, good evening, everyone. My topic today is about the point of care ultrasound echocardiography. I'll try to make it very simple. It is a long journey, learning journey, but I will try to make it simply. I will try to avoid complex medical word. It will be very simple, and we're talking about the basic point of care ultrasound, the basic view. So first of all, what is the meaning of point of care ultrasound focus, or sometimes it's called focus? Point of care ultrasound, as definition, is an ultrasound examination provided and performed at the bedside by the primary care physician or intensivist or emergency department or anesthesia, usually as adjunct to the physical examination to identify presence or absence of limited number of specific finding. So it is non-invasive, it is rapid test, it is answer a specific question. It's answer a specific question what you are searching for. So it is go with the clinical context or go with the clinical picture of the patient. So point of care ultrasound is a quick guidance to interrupt the echocardiography information and related it to the clinical context. It can be applied in the perioperative period, in intensive care unit, in emergency department, emergency situation, in trauma, in shock, and as resuscitation aid. And nowadays also it is included in cardiopulmonary resuscitation. So POCUS intended to assess the cardiac function, including contractility, chamber size, hypertrophy, valvular function or dysfunction, cardiac tamponading, pericardial, and volume status. So it is give you a rapid assessment of the overall of the cardiac and volume status. It is not conventional echocardiography. We are not measuring the valve diameter. We are not measuring the contractility by numbers. We are just estimated. It is rapid assessment of the cardiac function in emergency situation, and it is very helpful. It is very useful, and it is widely used now in the intensive care, in anesthesia, in the emergency department, especially when receiving a trauma patient, shock patients, whatever it is, septic, hypovolemic. It is very useful aid. So first of all, finding from the POCUS examination must, and I highlighted is must be correctly integrated into the clinical decision-making progress. So it is part of your clinical decision-making process. It is not a sole investigation. It is a part of your whole examination of the patient. And if you are not certain of all or part of the POCUS examination, you should not rely on those uncertain findings in the clinical decision-making process. For example, you have a shock patient coming to the emergency department, and the patient is shocked and is hypotensive. And you put the POCUS, and you can see the contractility is very well. This patient is still must be assessed as a hypotensive patient. It's not a matter of the cardiac function is okay, and the patient will be okay. It is a part of the clinical judgment. It is a part of helping aid that can help you. Okay, so this is in general the POCUS. Just to give you idea about the machine. Of course, there's different type of machine, but we have the fixed probe, the probe that we use in your hand. We have 3 type of probe. Actually, there's sometimes 4 or 5 type of probe, but the basic is 3 type of probe. The phase array probe, which is the we are talking about today. Phased array probe. Phased array probe is a cardiac probe, a linear probe, and convex probe. The linear probe can be used in the lung ultrasound. It can be used in the nerve block. It can be used in the assessment of vascular and many other issues, but this is not our topic today. And the convex probe, which can assess the deep structure, abdominal, for example, abdominal ultrasound in the liver, in the kidney, and in the nerve block also if there is a deep block. So we have three type of probe, sorry. Phased array, or we'll call it cardiac probe, the first one here, and we have the linear probe, and we have the convex probe. Just, of course, the physics is a very, very complex issue. As I said before, we'll try to make it very simple for us. Just one scope or one point of care ultrasound of the one we must knowing is the frequency. Frequency is how much the issue or happen in period of time. So the wave frequency, it is the number of wave happen during period of time or during a second. So we have two type of wave: high frequency wave, and we have low frequency wave. This is the high frequency, it's repeated many times, and this is the low frequency, which is repeated slowly. Okay, so as I said, we have the curvilinear probe. The curvilinear probe have low frequency, wide footprint, and penetrate deeper to the deeper structure, like here, the kidney. So you can remember like that, the low frequency, deep structure. It is low, so it is getting low. It is getting to the lower structure. And we have the linear probe, which is high frequency, linear footprint, shallow structure. And you can remember also like the high frequency, it is high, so it can show the higher structure. The low frequency can show the lower structure. And our probe is here. Our probe is a cardiac probe. It is 1 to 5 megahertz. This is the frequency. It is the same. It is the same like curvilinear probe. It is cardiac or phased array probe. Have low frequency. So low frequency, that means it's penetrating deep. You can see the deeper structure. Low frequency, narrow footprint, deeper structure. So what is the difference between curvilinear probe and the cardiac probe? The curvilinear probe has wide footprint, while our cardiac probe has narrow footprint, but it is low frequency. It can penetrate to see the deeper structure. About the basic movement, just to make the terminology is the universal, or to talk the same language in the POCUS, we have the fixed terminology, or we can understand each other. The movement of the probe. We have the sliding of the probe from one space to one space, anterior, posterior, lateral, medial. This is the sliding. And we have tilting. Tilting the probe is fixation of the footprint of the probe, and we are tilting the tail of the probe from angle to angle along its short axis. Rotation, we are fixing the footprint of the probe, and we are rotating the probe clockwise or anti-clockwise. Rocking, we are fixing the probe, footprint of the probe, and we are rocking from side to side, and this is called rocking along its long axis. So again, in sliding, we are moving from one space to one space. The other three here, we are fixing the probe, but just small maneuver, like tilting, rotation in the same place, rocking in the same place. Tilting, rotation, rocking will be in the same place. Sliding will be in other place. So again, sliding is the transducer is moved on the chest to any position to obtain the best window and in any direction. For instance, sliding the transducer from third to the fourth intercostal space or along the long axis of the heart while obtaining the Plex view. Plex view, we'll see it now. It's the parasternal long axis view. Tilting, as we said, it is fixed in the same plane, but we are tilting. The transducer is kept at the same plane on chest, and the angle of inclination is changed away from 90 degrees in either direction, with motion only along the short axis of the transducer to allow the other planes in the same axis to come in view. Rotation, the transducer is kept at the same place also on the chest and rotated clockwise or anti-clockwise to obtain different view from the same echocardiography windows. Rocking, the transducer is kept in the same place also on the chest, and the angle of inclination of the ultrasound beam is changed away from 90 degrees in either direction along the long axis of transducer. So compared with the tilting, during which the motion is along the short axis, rocking is along in the long axis. Okay, don't be confused. this is only terminology, but what is important for us is what is the basic POCUS view. As we said, we are not talking about cardiology or echocardiography. For cardiology, we are talking about POCUS, which is rapid assessment of the function of the heart and volume status. So we have 4 basic view: an emergency view, parasternal long axis, PLAX, parasternal short axis, BSAX. Okay, so we have parasternal long axis, parasternal short axis, apical 4, subcostal chamber view, and inferior vena cava view. This is the basic 5 view: parasternal long axis, parasternal short axis, apical 4, subcostal 4, and inferior vena cava view. We'll start one by one now. So if we're talking about parasternal long axis, PLAX, parasternal long axis view, okay, we are using the cardiac probe here. In each probe, there is an arrow. This arrow, I will show it to you here, sorry. You can see it here. This is the arrow, and this is the arrow, and it is on the other side of this probe. Okay, so in parasternal long axis view, we are directing the arrow toward the patient left shoulder as the arrow here. So that the indicator here on the transducer is directed toward the left shoulder. In the third or fourth intercostal space, immediately lateral to the sternum. So again, third, fourth intercostal space, immediately lateral to the sternum, directed the knob or directed the direction here to the left shoulder. What you can see now, what you can see if you apply it for parasternal long axis view, you can see from up to down, we can see here's the skin and subcutaneous tissue, the right ventricle, and here right ventricle outflow tract, or right, make it right ventricle now, and we can see the aorta. We can see part or basal part of left ventricle. We can see the left atrium, anterior mitral valve, and posterior mitral valve. So parasternal long axis like that, it is cutting the heart in lateral position and cutting that along, it is long axis of the heart. The heart is lying like that. Right ventricle, left ventricle, right ventricle up here, and left ventricle down. Right ventricle, left ventricle. From left ventricle going the aorta, and under it the left atrium, and the mitral valve going to the left ventricle. So this is the diaphragm of the parasternal long axis. So what you can see again, right ventricle outflow tract, the beam is coming from here. Here's our ultrasound probe, and the beam is cutting like that. We have right ventricle outflow tract. We have the left ventricle, the base of left ventricle. We can see the aortic valve coming from the left ventricle, the ascending aorta or the beginning of the aorta. Under the aorta immediately would be the left atrium. Coming from the left atrium, attached to the left atrium, the mitral valve, anterior mitral valve leaflet, posterior mitral valve leaflet, and the left ventricle. And this is the chorda tendini. And of course here, the posterior wall of left ventricle. Okay, and what is this one here? This is what we call descending aorta. So aorta is coming from here and turn it down to come from ascending aorta down behind the heart to be descending aorta. As you can see, this is the shallow. So whereas it will be the descending aorta, it will be behind here, behind the left atrium. Okay, so this is another left parasternal long axis. As you can see now, this is the fixed picture and this is the motion picture. Where is our probe? Our probe is here in the third or fourth intercostal space, and the marker is directed toward the left shoulder. So what is I can see here? This is a fixed right ventricle outflow tract, the septum. This is here. Most of the left ventricle, we cannot see the apex. If you can see the apex, this means you are not in the plane. You're supposed to see the base of the left ventricle. So this is the septum, and this is the posterior left ventricle, and here is the aorta, and you can see the cusp of the aorta coapting together, one cusp and one cusp is here, and you can see the left atrium, and this is the anterior mitral valve, and this is the posterior mitral valve. And what is this shining down? The shining down is the pericardium. And down here, it is not shown in the picture, but it's shown in other video, will be the descending aorta. Okay. So this is the first view, what we call the left parasternal long axis view. Okay. This is normal heart. This is normal contractility. Okay. Of course, as we said, it is a focal assessment. It is eye assessment. We are not measuring. We are trying to assess the left ventricle. So try to memorize, try to see normal patient. This is a normal patient. What do I mean of normal patient? The left, we are seeing part of right ventricle. It is small. As you can see, the septum here during systole, it is thickening. The myocardial get thickening here. This is the septum, and this is the posterior wall. As you can see, during systole, it is getting thickening. Okay, the aorta coapted together. There is no calcification. The calcification will be shining white. Okay, echogenicity. The echogenicity will be hyperechogenic. And you can see the mitral valve. The mitral valve is free, no vegetation, nothing. This is a normal mitral valve, and this is the posterior mitral valve. This is anterior mitral valve, and this is the chorda tendini. And if you can see, and this is very important, that the anterior mitral valve during diastole, it is attached during the diastole. Sorry, it is attached. It is almost touching the posterior wall or touching the septum. As you can see, this is the normal contractility, and this is very important sign, because when you assess the contractility of the left ventricle from parasternal long axis, we are assessing the size almost normal, the size almost normal. Okay, it is not dilated. You will see the dilated now. We can see during systole there is thickening of the septum, thickening of the posterior wall, and the anterior mitral valve is touching the posterior wall or touching the septum. This is adequate contractility or above 50% contractility. This contractility is normal, and the heart is not tachycardic. So this is how we can assess. And if you can see, there is no, this is the pericardium, no pericardial effusion down. This is unshining, no dark area or hypoechoic area here. So there is no pericardial effusion. If there is pericardial effusion, it will accumulate here in the posterior. And if it extended, it will accumulate here in the anterior. Okay, so it is nothing here. Okay, we'll talk about the view more and more. The other basic view is the parasternal short axis view. As we said, in the same plane, we are still in the third or fourth intercostal space, but the pointer here or the marker here, instead of the direction to the left shoulder, we are rotating, and as a rotation in the same plane, but we are only rotating the marker probe to the right shoulder. So in your same place, you are, if you go like that, here, the marker was directed toward the left shoulder, so we give you the parasternal long axis. If you rotate the marker in the same plane toward the left shoulder, sorry, the left shoulder, it will give you what? The parasternal short axis. You are cutting the heart in a cylinder. Okay, so what you can see here, we can see the left ventricle, the circle of left ventricle, and wrapped around by right ventricle. So left ventricle, circular, and slim, and like a small slip of right ventricle. And inside here, in this view, is the mitral valve like fish mouth. If you remember, the mitral valve like fish mouth. Okay. So this is what we can see. We can see the circular shape left ventricle. We can see either, depend on your level, you can see the papillary muscle, or you can see the mitral valve fish mouth. I will show it to you. And you can see the right ventricular cavity. This view is very important because this view will help us in assessment of right ventricular strain, or in case of pulmonary embolism. In case of pulmonary embolism, the right ventricular here will increase the pressure, so it will be not this, the septum here between the right and left will not be circular, that will be flattened. what we call D sign. D sign. It will be like a D sign here. We'll show it to you later, but this is the normal basic view of short axis. Okay, here's the short axis view. As you can see, this is a normal contractility. How we assess the normal contractility in short axis? As you can see, it is circular. I can see only a small part of right ventricle. It is not dilated, so the right ventricle is normal because the right ventricle is 1/3 or less the size of left ventricle, so it is very small. And you can see circular contraction of the left ventricle, and almost the muscle is kissing or touching each other. So this is normal contractility. Even this is not normal contractility, we can say this hypercontractile left ventricle. This means the patient may be hypovolemic, the patient may be tachycardic, the patient may have hypercontractility for any reason. But this is, as you can see, how we can assess rapidly. This is the normal or hypercontractile left ventricle. Okay, coming to the fourth view, which is the apical four-chamber view. Apical four-chamber view, now we have to slide the probe. Slide it from the third or fourth intercostal space to the fifth or fourth space below the nipple. And where the direction of my marker or the indicator, the direction will be at 3 o'clock. Sometimes this view is difficult to obtain, and actually, to be honest with you, this is the most difficult view for the beginner. So what you can do, you can put it in the most prominent, as we can, if you remember, when we hear the apex of the heart, we localize the apex of the heart by stethoscope, the most prominent part. When you can find the apex beat, you can put your probe and direct the marker toward the 3 o'clock. And it can help to tilt the patient toward the left side. So the heart will be drop, or the heart will be more on this side. So again, it is in the fifth or fourth to fifth intercostal space below the nipple, or most prominent part of the cardiac contractility, and the direction of the knobs or direction of the marker, it will be at 3 o'clock. Okay, and you can get this view. It will need a little bit training, but this is the view. What you can see, the classic view, the left ventricle, our probe marker is coming from here. The probe is coming from here. So we're cutting the heart like that, right? So we have the left ventricle. This is the septum of the ventricle. We have the mitral valve, the left atrium, the right atrium, tricuspid valve, and the small right ventricle. And from this view, you can see that the right ventricle and the left ventricle and the right ventricle. And the right ventricle is less than 1/3, comparing with the left ventricle. This is the view, the scheme of the view. We have the left ventricle, septum, mitral valve, left atrium, right atrium, tricuspid, and a small right ventricle. Okay. Now, this is the apical four-chamber. Okay, this is the fixed, and this is the view. What you can see now, the probe is here. You can see the left ventricle apex, the whole circle of left ventricle, the mitral valve, the left atrium, the tricuspid, the right ventricle. If you can see in this patient, the right ventricle almost equal, right? It is equal to the right ventricle. So it is we have here right ventricular dilatation, mild right ventricular dilatation, adequate contractility, and mild right ventricular dilatation. It is dilated, right? It's equal. So this is the normal. The left ventricle, the apex is the left ventricle. The right ventricle is not sharing the apex, and the size of left ventricle is larger than the right ventricle. The right ventricle is 1/3 of the size of the left ventricle. If it is like that, as you can see, the right ventricle start to go to the apex, and it starts enlarged. This means right ventricular dilatation. We're not measuring anything. We are just estimating. This is the POCUS. This is the focus. We are just measuring. Okay. The last view is the subcostal view. The subcostal view, your transducer will be in the subcostal area, subxiphoid, and the pointer or the marker will be directed to the left. And press a little bit, you will get this subcostal view. You are seeing the heart now from down. You are seeing the right ventricle, tricuspid, right atrium, left ventricle. This is the subcostal view. And the subcostal view is very important. My personal experience, I start to learn first the subcostal view. Why? Because subcostal view is very important in intensive care, and very important in emergency, very important in ER, very important in CPR, very important in everywhere. Why? Because you don't have access. There is many electrode here. The patient, the chest is splatted by mechanical ventilation. The patient have many electrode. The patient have surgery. The patient doing CPR here. So the only view or the only way you have access to the heart is the subcostal view, and this is sometimes called the emergency view. Emergency view, you can see the heart, whole heart. You can see the right liver up, of course, give you the acoustic window, the right ventricle, the left ventricle, and you can see, you can interpret most of the finding of the POCUS from the subcostal view. Okay, remember, our marker is directed to the left. All the marker directed to the left, except in parasternal long axis is directed to the right shoulder. Other here, directed to the left shoulder, directed to the left shoulder, 3 o'clock, and in the subcostal view, directed to the left side of the patient. If you turn the marker here from here to up in the same plane, sorry, we'll talk later. This is the liver, and this is the prime of the subcostal view. Right ventricle, left ventricle, right atrium, left atrium. Okay. If you turn the marker up in the same, where in the subcostal view we have the marker toward the left, right? Now we are directing the marker up, as you can see the marker here. But you can see the IVC view. The IVC view, this is what you can see. The liver, part of right atrium, and the IVC, inferior vena cava. And this is very important. What is the important? What I mean, you must, because under the inferior vena cava is the aorta. You can see two tube. Here is the ideal view, but in other view you can see two tube. You have to make sure that the inferior vena cava is coming from right atrium. It's not only tube, and you measure or assess the volume, because IVC, of course, is important for volume assessment. So you have to make sure that the IVC is coming from the right atrium. There is another thing, but this will be advanced a little bit, the inferior hepatic vein. You can see the inferior hepatic vein coming to the inferior vena cava. But you make to assess the IVC, you have to make sure that it's under the liver and is coming from the right atrium. Okay, now we finished the talking about the four basic view. We'll just talk about another issue. Now, what is this view? This is the subcostal view. The subcostal view, this is the liver, and here the right ventricle. As you can see, the right ventricle is small, right ventricle. Okay, the tricuspid valve, the right atrium here, the left ventricle, mitral, and the whole part of the left ventricle. You can see the apex, the endometrium contracted is very well. The endometrium is almost touching each other, and nothing here. This contracted is perfect. This patient is perfect. This patient is perfect. The right ventricle is okay, not enlarged, not small, not collapsible. And I mean the right ventricle is adequately volume, and the right ventricle contracted is very well. And you can see the valve is no calcification. This is adequate right ventricle ejection fraction above 50. We are not measuring, we are just eyeballing. Eyeballing, we are estimating. This is subcostal view. So you can get most of the finding from in emergency from the subcostal view. And if we turn the probe, as I said, to the up to the, make it perpendicular 90 degree, you can see the part of right ventricle, and this is mostly the tricuspid valve. And what is this? This is the inferior vena cava. Inferior vena cava. Inferior vena cava is coming from the right, and you can estimate the volume. I'll not talk about the measure today. I will just talk about visual estimation. What do you think about this? Right, the IVC. The IVC is normal. Normal IVC is 2 centimeters in diameter. You will measure it. You can measure. You can estimate it. Freeze the picture and measure it. But this is normal right ventricle. And it's not collapsible or mild collapsible. It is normal right ventricle. This patient is have adequate volume. Okay. So we'll refresh our. What this view is the left parasternal long axis view. Parasternal long axis view. This is of course not ideal view. Why not ideal view? Because I can see the apex. Supposed not to see the apex, right? So I can see the right ventricle, the septum contracted is very well, as you can see. The posterior wall contracted is very well. And I can see what else? I can see the descending aorta here, the shining of the pericardium. There is no pericardial effusion. And as I told you, you can see the anterior leaflet of mitral valve is touching the septum. So this is normal contractility. In spite of this picture is not ideal, it is not flattened, and you can see the apex. You cannot see the aortic part of the aorta, but you can still assess. You can assess the contractility. This patient have thickening of endomyocardium. Okay, the mitral valve is touching the posterior, the septum, so this is adequate contractility. This is rapid estimation. Okay, and as I told you, this is the descending aorta. Descending aorta is very important in this view. Why descending aorta is very important in this view? Later, when we talk about the pericardial effusion, this we can differentiate the descending aorta, position of descending aorta will differentiate between pericardial effusion and pleural effusion. But keep it later, because we are talking about the basic cardiac view now. Okay. This is parasternal long axis view. As you can see here, right ventricle, left ventricle. It is not an ideal view also, but it's a good view. What you can see here, you can see that the right ventricle almost collapsible, and this is what we call hyperdynamic left ventricle. As you can see, it is not an ideal view. You don't have to be perfect in echo. By training, you will be perfect. This is a beginner echo, but as you can see, this we can assess the contractility. This patient have poor contractility. No, this patient have good contractility, even it's hypercontractile left ventricle. Okay, but what about this view? This is a parasternal long axis view. As you can see, the mitral valve almost opening, not touching the wall, and dilatation of left ventricle. There's no contractility or enlargement of the septum, enlargement here. This is a poor cardiac contractility. This ejection fraction is less than 50%, maybe 30%. Okay, this is for parasternal long axis view. This is another patient. Left parasternal long axis view. You can see dilatation of the left atrium, dilatation of the heart. Now the operator going to the, I will fix this view. So the parasternal short axis view, as you can see, the dilatation of the left ventricle and flattening of the septum. Flattening of the septum mean pressure in the right ventricle, and the right ventricle start to flatten septum, what we call D sign. You can see the D sign, right? D sign here. And poor contractility. This is the mitral valve, fish mouth mitral valve, and poor contractility. This is the D sign. You can see it here. And back again, you can see dilatation. The mitral valve is not touching. And there is dilatation, as you can see, of the this is very poor contractility. This patient need inotrope, not volume. It's dilated already. What about this patient? This patient is tachycardic. And dilatation, as you can see, dilatation and D sign, it is the right ventricle and the D sign, and the right ventricle almost not contracting, right? It's almost like just moving, right? This is very poor contractility. Okay, this is the apical foreview. What you can see, dilatation of the left atrium, dilatation of right atrium, and the right ventricle. This is the right ventricle. The left ventricle is dilated. We can continue. It's dilated, right? It is very thinning. Not adequate view, but you can assess. You can still assess the contractility. Right? This is poor contractility by eyeballing. This is what? This is a subcostal view. You can see 1 minute. Here, subcostal view. The dilatation of the left ventricle. Right ventricle is okay. And what is this? This is a rim of pericardial effusion. Here, rim of pericardial effusion. And if we go to the IVC view, this is the aorta. Okay, this is the IVC. IVC you can measure it by M mode. It is dilated and non-collapsible, right? The IVC. What is this? Short axis view. Short axis view with good contractility, almost kissing each other, right? Short axis view. Right? Circular, septum is okay, and almost the muscle attached to each other. How about this one? This one, circular really, but this is poor contractility, no flattening of the septum, right? But the contractility is very poor, not very poor, but mildly depressed. because it's not attaching it or not coming to each part of the papillary muscle. Okay, this is another patient, short axis view, and you can see it is very good contracted, and even this is one touching is too much. This is hyperdynamic left ventricle from short axis view. Apical fourth chamber, apical fourth chamber. This is the normal. There is a septum is thickening during systole. That the left ventricle, right ventricle. It is normal, but it is not in the brain, but it's normal. The left ventricle contractility is lifting up, and the contractility is very well. This is normal view of the apical fourth chamber. How about this one? You can assess visually. We are not estimating. We are not cardiology. We are talking visually. As you can see, there is thickening myocardial hypertrophy here. You can see the myocardial hypertrophy, right? The myocardial hypertrophy, small right ventricle, and good contractility, right? It is good contractility for the left ventricle. The muscle is getting thick. The cavity is collapsible, but as you can see, there is hypertrophy here of the muscle. So hypertrophic heart. This is another view. As you can see, the muscle is thickening. The cavity is small, ejection fraction is very high, ejection fraction is okay, but still we have hypertrophy. This is another one. You can see, you can appreciate what you can see now. This is both of them, dilatation of the left ventricle and hypertrophy of the muscle, hypertrophic cardiomyopathy. Small right ventricle, and hypertrophy of the muscle. You can see the muscle, how it is hypertrophied all around the left ventricle. It is symmetrical hypertrophy of the left ventricle. From apical fourth chamber. Okay, apical fourth chamber view. This is another patient. Apical fourth chamber, the operator tried to adjust his hand by tilting, by rocking, but anyway, he gets the view, and you can see here what is the abnormality. We can see here, we can see dilatation of the right ventricle, right? Dilatation of right ventricle. Okay, here severe dilatation of right ventricle. It is a very difficult view. It is advanced a little bit, but this is called McConnell sign. McConnell sign is the dilatation of the right. This is the left, and this is the right. Apical fourth chamber. This dilatation of the right ventricle. The septum is going in the stole, going to the left ventricle, and as you can see, the dilatation and almost the apex is formed from the right ventricle. The left ventricle is pushed, and there is poor contractility of the apex and powerful contractility or power contractility in the apex. This is called McConnell sign, and this can give you a clue that there is right ventricular stain or pulmonary embolism. It is go with pulmonary embolism. It is not 100%, but it can suggest pulmonary embolism. This is called McConnell sign. Okay, this is another view of a patient from apical fourth chamber, and we can see this contractility is good. There's mild hypertrophy, but anyway, this patient for assessment as emergency have a good contractility, have good size of the right ventricle. Okay. Okay, this is another patient with symmetrical hypertrophy of right ventricle, symmetrical hypertrophy, and poor contractility. Poor contractility, you see dilatation. And this is the mitral valve. And almost from hypertrophy, this very small right ventricle. So ejection fraction here, we can estimate it how much. If you put your finger in the middle here and check how come the wall come to the center, not coming to center. Almost, this is around 40 or 30% contractility, ejection fraction. Now coming to my favorite view, subcostal view. This subcostal view with normal contractility, and you can see the liver, right ventricle, left ventricle down. Another subcostal view, liver, right ventricle small, left ventricle contractility, the septum is okay. this is the papillary muscle and the mitral valve, right atrium, and the contractile is very nice. For rapid assessment, this is the small right ventricle. The patient is volume is okay. The patient contractility is okay. Okay. This is one of my patients. Very important. Why? You can see that this is subcostal view. What you can see here, this is pericardial effusion almost, and down the liver, anterior and posterior pericardial effusion. And what you can see in the pericardial effusion, the pericardial effusion is collapsible. This is sign of tamponade. There is a collapsible of the right ventricle during systole, during the diastole. So during diastole, collapse of right ventricle. This is cardiac pericardial effusion with pericardial tamponading from the subcostal view. Another subcostal view. We'll pass it now. Okay. So if we talk about the pericardial effusion, this is how it looks. This is how it looks from the parasternal long axis. This is the parasternal long axis. There is anterior pericardial effusion and posterior pericardial effusion. And what is this? This is the descending aorta. Descending aorta is here, right? So if the descending aorta and the pericardial effusion here, and the effusion is here, this is pericardial. It is down to the descending aorta to be pleural effusion. But anyway, this is pericardial effusion, not tamponadic. Why not tamponadic? It is not compressing the right ventricle. Here, in the subcostal view, there is pericardial effusion. Do you think this is tamponadic? Yes, it's tamponadic because it's compressed the right ventricle, and this is pericardial effusion from subcostal view. To assessment of pericardial effusion, you can say, if it is not tamponadic, you will say it is mild, moderate, or severe. Mild, moderate, severe, depend. You can measure how many ml here. For example, this is more than one. If we freeze the picture and we measure one, less than one, it is mild. More than from 1 to 2 is moderate. Above that, it will be severe. Okay. From inferior vena cava view, we can assess the right atrial pressure, right? Because we say that the inferior vena cava is a reflection of central venous pressure. Okay. Normal physiology, the inferior vena cava collapse with inspiration. This is normal during spontaneous breathing, and be reversed in post pressure ventilation. So, if you can see, this is the right. This is the subcostal view and the inferior vena cava with the inferior vena cava. This is the right ventricle. It's collapsible with inspiration. So average IVC, as we said, it is 2 centimeter and above, and we can assess the collapsibility. This is the range. It is a little bit advanced. To make it easy for you, I like this slide. Why? It is very simple. This is if the IVC diameter look normal, collapsibility is normal, right atrial pressure around 3 millimeter mercury. If the IVC diameter is normal, but collapsibility like here is not is abnormal, it's not collapsible, right? So it is 8 millimeter mercury. Abnormal IVC diameter was normal collapsibility, it will become 8. Abnormal IVC diameter or abnormal collapsibility, it will be 15. Okay, I'll make it simple for you. You can say that this is the IVC. The IVC is dilated, non-collapsible, congested, plethoric IVC. Plethoric IVC. This is plethoric IVC. This is dilated, right? Dilated more than 2 centimeter, and it is not collapsible. So this is dilatation. This is no need for volume infusion. This patient, we have be very cautious with volume infusion. This patient have collapsible IVC. So non-collapsible IVC, non-collapsible IVC. Dilatation of IVC, no dilatation of IVC. Make it simple. In advanced way, you can measure the IVC. This is collapsible IVC. You can see from the IVC, it's collapsible. So this patient can receive more volume, right? You can put the M mode. In another lecture, we'll talk about the other mode. You can put the M mode here and fix, and you can measure the IVC. You can measure from wall to the wall. It will be less than 1 centimeter. So the patient can receive more volume. Or the patient the volume status is this can high normal volemic or hypovolemic, depend on the pressure. How about this patient? Also, IVC, this is normal IVC, normal. It is not it's collapsible with inspiration, right? With inspiration collapsible and normal volume, depend on his blood pressure. I'm measuring here. Okay, this is a complete POCUS examination. You can see this is the parasternal long axis. The left ventricle is very good contracted. The mitral is touching the septum. Now coming to the short axis, what you can see here, I will stop here this time. This short axis, it's a little bit advanced short axis at the aortic root, at the aorta, sorry, aortic cusp. Aortic cusp appear like Mercedes sign. Long plexi parasternal long axis will turn now to the short axis in the same space. You can see the round, this is the aorta. Now coming the circle left ventricle and the right ventricle around it. It is normal. I can see right ventricle normal, contracted is very well. Contracted is very well. Circumferential, papillary muscle is okay, contracting very well. Apical fourth chamber, you can see the endocardium, contracted is very well. Left ventricle, right ventricle is small, and the contracted is very well. Nothing, mitral valve or thoracic. And this is a little bit advanced. This is the color. You can see the regurgitation. This is a little bit advanced, but we're talking about the basic view. We just want to understand or orient about the basic view. Okay, and this is subcostal view, which is normal subcostal view. Very nice subcostal view. Ending by inferior vena cava view. So I want you to remember one thing. One view is not a view. You have to assess the cardiac. You cannot put your probe and parasternal long axis and say this is poor contractility. You have to assess apical parasternal long axis, parasternal short axis, apical 4, and subcostal view to say this is poor contractility. So just remember this one because this is very, very, very important. I will say it is a part of clinical judgment. It is not the end of clinical judgment. POCUS, we're not talking about cardiac echocardiography, cardiology echocardiography, or we're talking about emergency echocardiography. So one view is not a view. Thank you very much. I hope give you a good information and you will get useful from it. Thank you very much. Yes, Dar.
Thank you so much, Dr. Imam, for this presentation. Everyone, we do have a couple of knowledge check questions for you to see if you follow the presentation. So give me 1 second. Our first quiz question, you should see a picture on your page and tell us what is the name of this cardiac echo view. There are 4 options for you to choose from. So please take your time to respond, and Dr. Imam then will help us to get the correct answer for us. Okay, I see about 50% of people who are here answered the question. So we'll give another 10 seconds. Okay, so I'm gonna end poll and share the results. And Dr. Imam, do you wanna comment on the correct answer?
Very nice, very nice. Yes, yes. This is parasternal short axis view at the level of mitral valve. This is the 90%, 90%, yes, 90% get yes for my lecture. This is the parasternal short axis view. Thank you.
Great. Okay, moving on to the second question. There you go. What is the name of this cardiac echo view? You should see the picture, and there are again 4 answers for you. Okay, I see people are participating. About 60% who is present. Answering, so I'll give another 10 seconds. So
Is the most important emergency view.
all right. Let's see. Let's launch this responses. There you go, Dr. Imam. What's the correct answer here?
Subcoastal view. This is a classic subcoastal view. Parasternal, 32% say parasternal long axis. No, of course, this is not left parasternal long axis. The left parasternal long axis, you will see the right ventricle outflow tract, the left ventricle, aorta, left atria. This is the subcoastal view, and you can see here up here. This is the liver, right ventricle, left ventricle. This is a subcoastal view. Thank you, subcoastal
All
view.
right. And we do have another last one, knowledge check. Same question. What is the name of this cardiac echo view? Four answers for you. Please choose the one that you think fits the most. Oh, I see people are just responding real fast. So about 50% of you responded. So let's see, maybe 10, 15 seconds. All right, let's share these results. And Dr. Imam, what is the correct answer here?
Very nice, very nice. Yes, parasternal long axis view. This is the classic left parasternal long axis view, not apical. And maybe we can confuse the subcostal view, but not confuse with the apical. Apical, you can see the both right apex. You can see the apex, right? This is exactly parasternal long axis view. Thank you very much.
All right, thank you so much. And last question is, if you can answer this question, this will help us to plan our future webinars, and you can leave feedback if you'd like for Dr. Imam or us for future topics or anything you would like to share. So I'll leave this question open, and we can move to our Q&A portion of the webinar. We have about 6 minutes in until the end of the webinar. So let's see.
Okay, I will answer for Dr. Balkarshan. And maybe I'm mistaken. Yes, you are right. The anterior and posterior leaflet, I said maybe I'm, by mistake I said the anterior posterior mitral valve. No, you are right. Anterior and posterior leaflet mitral valve. He said inferior vena cava is not a common, but going to right atrium. No, inferior vena cava view is very important. Yani inferior vena cava view is very important for assessment of volume status. You have to assess the inferior vena cava. Regarding this is the only question?
Yeah, I
Okay.
think that's the only question. I think
Okay.
there is some chat conversations about this may be a minor mistake, but it's okay. I think we figure it out. But if anyone would like to submit any questions, you can put it in a Q&A box. We still have some time, and I see we still have 140 people watching us. So if you don't have any questions, we thank you so much for joining. We really appreciate you taking the time. This webinar was recorded and will be shared with you all next week around Wednesday. So you'll receive an email from us. But again, we appreciate your time. Please answer the poll question before you leave. This will help us to plan future webinars. And we do hope to see you next time in our next webinar in March. That will be about ectopic pregnancy. So if you're interested in that, we'll see you then. Let's see, if there are any questions. We do not share a transcript. However, we share a recording. I see one of the questions. So The recording will be posted on the website, and then you'll get a link next week, as I mentioned that. Dr. Imam, I think there's one more question about probe markers.
Okay, yes. This is a technical issue regarding the probe markers. Yes, all the cardiac, and you set your machine to the cardiac view. The cardiac view it is adjusted like that. The marker will be on the right side, and all the pointer will be toward the left shoulder only, toward the right shoulder only in parasternal long axis, and to the left side in the other view. This is different than abdominal probe and OB-GYN probe or the gynecological probe. Yes, but you set you have I was supposed to highlight this one at the beginning of the examination of the POCUS. You have to set the machine of the cardiac view or cardiac setting. So the cardiac setting will be adjusted like that. The marker will be on the right side, and the setting will be like I said. This is a little bit technical issue in the machine, different than abdominal probe and the other probes. There's no particular reason, I mean.
Well, I don't see any. Oh, there's just one. Do we get a CME for this webinar? There is no CME credits for the webinar. But I do hope you found this information helpful, and the presentation was great. So, if there are no questions so far. So again, thank you, Dr. Imam, for joining us today and presenting the webinar with us. We hope to see you next time, maybe for other topics if you'd like, but we appreciate you taking the time. And thank you everyone who joined us today. Have a great day, evening, wherever you are, morning. We'll see you soon. Thank you so much.
Thank you very much. Thank you very much.
Thank you.